Perfect. Thanks so much, Priya. Hi, everyone. My name is Lakshmi. If you don't know me, I'm one of the third year GI fellows at UCSF, and I'll be introducing our speakers for the month of July. And just a few ground rules for our new fellows. Just make sure you have your video muted unless you're intending to speak. And if you do have a question, feel free to unmute and ask or type it into the chat, and I'll help monitor the questions for our speakers. And we will try to have a quick stretch break in between our speakers, so not to worry. So without further ado, I'll start with introducing Dr. Colin Feuille. He is one of our attending gastroenterologists who's based out of the San Francisco General Hospital. He completed his MD and internal medicine residency at Mount Sinai in New York before coming to UCSF for GI fellowship, which he completed in 2021. And after a brief stint at Kaiser, he returned to us at UCSF and the General. Outside of direct patient care, Colin is really passionate about medical education, and he wears a lot of hats in this realm. He's the co-director of our medical student inquiry curriculum, director of the student and resident GI electives at the General, and serves as one of our coaches for the GI fellows. And his current research focuses on the role of peer teaching in endoscopy education. And just last year, he rolled out an innovative curriculum to teach the senior GI fellows to help learn the principles of effective endoscopy education. And as a San Francisco native and an avid skier, feel free to ask Colin if you see him around about any questions related to those things. And so with that, I will turn it over to Dr. Foy for his talk on upper GI bleeding.
Thanks for the intro, Lakshmi. Hi, everyone. It was nice to meet some of you at the happy hour on Monday, but excited to kick off our Grand Rounds series this year with everyone's favorite topic, GI bleeding. So Wasim and I have a double header of upper and lower GI bleed today. Hopefully this will be a little bit interactive. I may kind of pose some questions to the audience. Feel free to stop me at any point with questions. There's not been a huge amount of new practice changing stuff in the last year on GI bleeding, so this will be very similar to last year, but Wasim and I did make some updates to try to remove some of the redundancies between our two talks. So hopefully it'll be fun and helpful for all of you. So with that, objectives today, we'll try and formulate an approach to patient presenting with upper GI bleed, including taking a targeted history, exam, lab evaluation. We'll work on differentiating the medical and endoscopic management of upper GI bleeding based on the source, again, focusing on the acute inpatient setting. Identify the necessity, timing, and appropriate location of endoscopic procedures. And we'll really focus on peptic ulcers as the most common cause of upper GI bleeding. And let's talk a little bit more about the endoscopic and medical therapy of ulcers. So just very briefly to review anatomy, we consider upper GI bleeding to be anything proximal to ligament of Treitz, which basically is anything that you can reach with a regular upper endoscope. So esophagus, stomach, and the beginning of the duodenum. Anything beyond that in the small bowel is considered small bowel bleeding, and then in the colon is generally considered lower GI bleeding, which will be the next hour. Upper GI bleeds are very common, but have been decreasing in etiology over the last 15 years or so, probably due to increasing PPI use for other things like GERD and functional dyspepsia, as well as increasing recognition and treatment of H. pylori as both a cause of peptic ulcer disease and a risk factor for gastric cancer. So it does still account for a substantial number of ED visits and hospital admissions, but overall has been decreasing, although there hasn't been a great, large study on this epidemiology in quite a while. To welcome all our new first-year fellows to GI Fellowship, we have a haiku page that is going to be very, very similar to what you'll get in the next probably the next few weeks. 44-year-old man admitted, found down in a pool of coffee ground emesis and melena with tachycardia and hypotension, and you're called by the ER to come admit this patient or see them as a consult rather, because you're not admitting anymore. What do you want to know about each of these? Like the history, the patient's comorbidities, meds or substances, prior procedures, and physical exam. What would you focus on as the GI fellow seeing this patient? Ask Maddie to share. What do you think?
I was just about to unmute. Yeah, maybe I'll take the first bullet point of HPI and kind of just, I guess, first with review of systems, asking about kind of duration of symptoms, severity, lightheadedness, dizziness, associated symptoms, such along those lines, and then really diving into like the PMH, inquiring about like past episodes of this, history of cirrhosis, history of POD, NSAID use, steroid use and anticoagulant use. And then I would also just like do a dive through, oh, I guess procedural history is down there, but do a dive through this procedural history as well to kind of corroborate that.
Great, awesome. Yeah, love all that. So definitely focus on, characterizing the bleeding, how long it's been going on, what type of bleeding, how much. We really care about what the stool color is, whether it's melena or hematochezia, like bright red blood, any other associated GI symptoms such as pain or dysphagia that could point to specific etiologies of bleeding. We want to ask about signs that might suggest more severe bleed or more severe anemia, including orthostatic symptoms or dyspnea. Obviously, if someone's had prior GI bleeds, that's important to know about because that could suggest that they're having the same thing. As Maddie mentioned, we definitely want to watch out for liver disease or cirrhosis or other signs of portal hypertension, which will put you at risk for varices and other kinds of bleeding sources. And then things that are going to increase risk of bleeding, like coagulopathy, aspirin, NSAIDs. NSAIDs more for peptic ulcer disease risk, but antiplatelets, anticoagulants certainly are going to make any kind of bleeding source potentially more severe. And then we mentioned looking at the procedural history. So if they've had prior foregut surgery, for example, a bariatric surgery, a Roux-en-Y, they may be more at risk for certain sources like anastomotic ulcers. And then prior things like endoscopy, radiation, which could put them at risk for radiation-induced damage to the GI mucosa. And then finally, something that you really want to focus on that's I think probably different than what you might do when seeing these patients as a medicine resident is ask about the kind of the important pre-procedural questions, like when was the last time they ate? What was that? Was that food, solid liquids? Because the anesthesiologist will want to know that. And then are they consentable? If they're not able to consent, who would be their surrogate, who you would ask to get consent for a procedure? And then we're going to focus on doing a physical exam. And for us, our most important part of the physical exam is the rectal exam. And by rectal exam, I really mean a stool exam, because if some patient has a bowel movement right in front of you and you can look at it, you probably actually don't need to stick your finger in their bottom and get some stool. So we're really looking for the color of the stool and looking for whether it's melena, which is that dark, black, tarry, sticky stool. Like I say, you know it when you smell it, and you're going to smell a lot of it during the GI fellowship. It actually does not take that much blood to cause melena, even as much as all those little like travel-sized liquor bottles you get on the airplane. That is enough like volume of blood to turn a stool melenic. So if someone is having a large volume upper GI bleed and they're having, they usually should see it as melena. If someone is having brown stool, it's probably not a large upper GI bleed, with the one possible exception being that it looks like it just happened, like someone is clearly like having large volume hematemesis and like their last bowel movement was half an hour ago and the bleed just started. It may not have a time to turn black yet, but it will. So again, we really focus on stool color, whether it's brown, black, or red, essentially. When we're looking at vomit, obviously, like fresh red blood is going to be more concerning than coffee ground emesis, which probably has been in the stomach for some time to turn dark. Melena obviously is usually suggests an upper GI bleed, but can also be seen with kind of small bowel and right colon sources if they're kind of more slow and have time to turn into melena. Whereas hematochezia typically is going to suggest a lower GI bleed, with the exception being if it's a large volume of bright red blood in an unstable patient. You definitely still want to be concerned about an upper GI bleed because it's moving through so briskly that it doesn't have time to turn into melena. This should go without saying in a talk for a GI audience, but no one cares about the FOBT. You can just tell the ER to ignore that and to not send that on any kind of stool when you're suspecting a GI bleed. So again, focused physical exam, looking at vital signs, orthostatics, whether they're getting better with resuscitation is really important. If someone who is responding appropriately to resuscitation is a very different picture than someone who is not. And again, really brief other exam focusing on general appearance. Again, mental status. Are they talking to you? Or are they so anemic and volume down that they're not able to mentate properly? And really the big picture is that the exam should focus on whether they are stable or unstable and whether they're having signs of ongoing active bleeding or whether you think the bleeding is stopped or stopping. Something you'll hear kind of tossed around sometimes is the idea of doing an NG tube for a gastric lavage. This is generally fallen out of favor, mostly because it's not a very sensitive or specific test for high risk upper GI bleed. If you have it, put an NG tube down and you aspirate the contents, a true negative NG lavage brings back green bilious fluid. And the idea there in theory is that the NG tube is past the pylorus and is like suctioning duodenal contents, and that you're actually kind of sampling the whole upper GI system. But like I said, it's not a very good test. Up to 15% of people with clear or bilious lavage end up having high-risk lesions when they get scoped, and up to 40% with bloody lavage end up having low-risk lesions, which we'll come back to what that exactly means later in the talk. So it's certainly not something I would put an NG tube down just to do this. If someone is like in the ICU already and has an OG tube, for other reasons, and then they developed an upper GI bleed during their stay, sure, it's reasonable to aspirate some of that contents, but certainly not, I think, worth putting someone through just for the lavage. We really care about having good IV access when treating someone with an upper GI bleed, and really focus on using the large bore peripheral IVs, with the green kind of 18 gauge being our preferred size, assuming you can get one in. And the reason for that comes back to a little bit of physics. Puiseuil's law dictates that the flow is proportional to the radius to the fourth power. So a very kind of large radius is going to massively increase your flow, and it's also inversely proportional to L, the length of the catheter. So short, fat catheters give you much higher flow rates than longer, thin catheters. This is illustrated here by comparing the flow rates of different types of devices, and you can see that the 18 gauge small peripheral IV has a much higher flow rate than the same kind of 18 gauge in a triple lumen central catheter. There, the central line is a much longer length of the catheter, and that dramatically reduces your flow rate. The most recent GI bleeding guideline for upper GI bleed that we have is from the ACG in 2021. That'll form kind of the spine of the rest of this talk. So the first recommendation is that we do some kind of risk stratification. And the two scores that are highlighted in the guidelines are the Glasgow-Blatchford score, which is a much more kind of complicated score, which has a lot different factors that go into it. And it is best validated for predicting low risk lesions. So a score of 0 to 1 generally can be safely discharged from the ED because they have very low risk mortality or other complications from their GI bleed. These people can get an elective outpatient endoscopy in the next couple of weeks. The AIMS 65 score is much smaller, has just albumin, INR, altered mental status, blood pressure, and age, and is the best validated score for predicting mortality. So higher scores are associated with higher in-hospital mortality risk, and this might be helpful in deciding who you would send to the ICU, but not so helpful in deciding who to discharge. Again, this is something that our colleagues in the ER should be doing when they're seeing these patients. And fortunately, in this GI fellowship, we don't generally take consults from the ER where we're helping them decide whether to admit someone or not. So you may not actually be using this so much in your daily practice, but it's something worth knowing about because it is something you're going to have to keep in mind for the future. Now that you've seen someone with a GI bleed, they're starting to get resuscitated. What would you recommend for blood transfusions? Is there data to support that recommendation? And maybe I can ask Vincent to share. What have you seen GI consults typically recommending for blood transfusion thresholds?
I've seen to minimize pressure on the lesion is adopting a more conservative strategy, hemoglobin of 7.
Great. Yeah. So that is our usual recommendation. That comes from an RCT that's over 10 years old at this point. The largest trial of this randomized patients to a restrictive versus liberal transfusion strategy of 7 versus 9, and found that the restrictive strategy was associated with lower overall mortality compared with the liberal transfusion strategy. And it is thought that the liberal strategy was, as Vincent said, leading to increased portal pressure from increasing volume of blood you're putting into the portal system, which is going to feed a lot of GI lesions and lead to more rebleeding. Although if you look at the subgroup analysis, that really was driven by people with child A and B cirrhosis, who really derived the biggest benefit from the restrictive strategy, which again makes sense because their etiology is most closely tied to portal hypertension. Importantly, this trial excluded patients with massive exsanguinating bleeding. So if someone is in hemorrhagic shock, that this goes out the window. You should be using blood as a resuscitation fluid because the blood is what they're losing, and that's a scenario where you would consider using a massive transfusion protocol. Remember that hemoglobin is a concentration; it's grams per deciliter, and so that needs time to equilibrate. When someone acutely first starts bleeding, they're losing whole blood, so the concentration is going to stay the same, and then over the course of the next couple hours, as fluid redistributes from the extra interstitial space, as well well as from the resuscitation fluid, like normal saline or plasma light that you're giving to resuscitate, that's going to dilute the hemoglobin down to some level. So again, when someone is if someone is in hemorrhagic shock, but their hemoglobin is 15, the bleed just happened and it's a really large bleed. You should still be giving blood as a resuscitation fluid. And we do also sometimes consider a higher transfusion thresholds for people with significant cardiovascular disease. And also orthopedic and like cardiac surgery guidelines recommend a higher transfusion threshold for anemia in these patient populations. I think mainly because, again, heart, obviously, that makes sense. It comes back to physiology. Delivery of oxygen is proportional to the cardiac output times the hemoglobin times the oxygen saturation. So someone who has very poor heart, poor cardiac output, or poor lungs with low oxygen saturation is going to need a higher hemoglobin to bring up their tissue oxygen delivery. And then orthopedic surgeries tend to be pretty bloody, so they like to have them tanked up a little bit more before that. Great. So should we give the patient a PPI? What is actually the evidence for PPIs, and what do the guidelines say? Ava, do you mind sharing some thoughts on this?
Yeah, of course. I'm not sure exactly what the guidelines say, but the practice I had as a resident was always to give a PPI, usually IV load, and then BID PPI if they're actively bleeding.
Great. Yeah, so that is definitely our practice, although the evidence for PPIs is actually kind of weak, especially for pre-endoscopic PPIs. So overall, giving a PPI before endoscopy doesn't seem to overall affect mortality, further or rebleeding rate, as well as need for transfusions. What PPIs before endoscopy do seem to do is decrease your need for therapy during the endoscopy and decrease your risk of finding high-risk lesions. And it may also decrease your risk of rebleeding after endoscopic therapy for high-risk ulcers. As we'll come back to later, people who do have high-risk ulcers definitely need a high-dose PPI after the endoscopy to help that lesion heal. So I think there is certainly some rationale to like start the PPI early in case someone is going to have a high-risk ulcer. You're starting that kind of like stabilization process earlier. We know platelets tend to work better at aggregating in a higher pH environment. So that this forms the rationale for giving PPI early. And again, I think, in some cases, endoscopic therapy ends up being delayed or not done. Like, for example, if the patient is like having a STEMI and needs to go to the cath lab before they get their endoscopy, you want to have the PPI on board to like at least temporize the situation. As Ava mentioned, there's a lot of data at this point to support equivalence of IV PPI, BID, and IV infusion. And there's even actually some studies of giving like really, really high dose PO PPI versus IV, like 40 milligrams 4 times a day of an oral PPI. That oral PPI is definitely not standard practice, but we have basically universally moved to giving IV PPI BID because the drip doesn't seem to be that much better. So our current practice, as Ava said, is to recommend giving a high-dose bolus of IV PPI up front and then continuing 40 milligrams IV BID starting before endoscopy. And then we modify that strategy based on what we find during the endoscopy. There is possible cost savings associated with decreased endoscopic therapy. Also, if we kind of downstage lesions to ones that don't need endoscopic therapy and don't need that like 72 hours of observation after the endoscopy, those patients could potentially be discharged earlier, and that's going to be a significant cost savings compared to the cost of a PPI before the endoscopy. Again, as I mentioned, possible benefit if the EGD will be delayed. And then again, we're starting therapy earlier for those patients who ultimately will need the PPI. And I think a lot of the issue with like the pre-endoscopic PPI not showing a lot of benefit overall is that you're kind of taking all comers in this case. And like the people who end up having very low risk lesions, they probably don't derive that much benefit from it, but they're diluting the population of who have the very high risk lesions when you look at everyone before you've done the endoscopy to figure out what they have. All right. Is there any other medication we should give before we do an endoscopy? And I'll say like this is maybe a little bit of a read my mind question. So I'm not talking about people with cirrhosis who need like octreotide and antibiotics.
Can you do like a pro-motility agent, like
Yeah.
to make the
Awesome. Yeah. Yeah, perfect. Exactly what I was asking about. So, so prokinetics. So again, the rationale here is that we don't want to spend an hour suctioning a bunch of big clots out of the stomach. So giving a prokinetic to empty the stomach can be helpful in allowing us to visualize the lesion more. The one that is in the guidelines is actually erythromycin. We give a 250 milligram IV dose about an hour before the scope. And the reason for that is erythromycin obviously is an antibiotic, but it's also a motilin agonist, which is a pro-GI motility hormone. And so it's not really really used so much as an antibiotic anymore because it gave a lot of people diarrhea and GI upset because of that motulin agonist property. But it's great for us because it helps promote motility. We also use it in gastroparesis. Some things to really keep in mind logistically, though, is that it can sometimes take a while to get from the pharmacy. They usually have to mix it up when you put in the order. So you have to think about it well in advance. And actually, at the General, we have right now a massive shortage of erythromycin. So we're actually not able to get it at all unless people actually need it as like an antibiotic. The alternative that you can consider using is metoclopramide, as Quentin mentioned, which is much more readily available. It's not endorsed by the 2021 guideline due to a lack of evidence, although there was a new small randomized controlled trial published in the Red Journal last year that gives a little bit more evidence to support its use. This was done in 2 Thai hospitals where they randomized patients to metoclopramide or placebo. They were all planned to get an EGD within 12 hours after arrival, which, as I'll come back to in a minute, is definitely a little bit quicker than our average time to EGD for most by guidelines at least. But they gave a 10 milligram IV dose and then followed half an hour to 2 hours later with an endoscopy. The study did include patients with cirrhosis and had similar rates of cirrhosis, esophageal lesions, gastric, and duodenal lesions in each group. And this was their kind of primary outcome. There was no difference overall in adequate visualization overall between the 2 groups, but they did see an increase in visualization in the subgroup of people with gastric lesions, which I guess makes sense since what you're really trying to do is empty the stomach of blood. And they did have this. It's a little bit disingenuous because they say like significant decrease in second look EGD. Although if you actually look at their table, the full like sentence here is second look EGD due to an unidentified lesion at the index EGD and rebleeding. So certainly like if you don't find it the first time, then like yeah, you might be much more needing to do a second look EGD. And there was actually a numerically lower rate of an undetermined lesion due to blood clot in the stomach in the metoclopramide group, although the numbers were small. They didn't give any p-value on this. So again, it's a small trial. There's some data. Certainly, like it's probably better than nothing if you can't give erythromycin. But if you have erythromycin available and you have the time, it is still what the guidelines recommend. All right. So when should we scope the patient? Is there data on the timing of endoscopy? And maybe I can ask Sean, what would people do at NYU? How quickly would they get a scope there?
I think that there's isn't like a huge rush in terms of like outcomes to scope. I think say like 24 or 48 hours.
Yeah, perfect. So generally, there actually was a randomized controlled trial looking at this question a couple of years ago, published in the New England Journal. So this randomized people to urgent within 6 hours versus early, which is defined as between 6 and 24 hours. Again, like our transfusion trial, this excluded people who were like having massive bleeding. So excluded people in hypotensive shock or who were unstable despite initial resuscitation. So this timing does not apply to those patients, and they really will need an earlier endoscopy because you're going to actually need to do hemostasis to help get them stable. But in patients who are stable and responding to resuscitation, there was no significant difference in 30-day mortality, further bleeding, duration of hospitalizations or transfusion with scoping within 24 hours compared to within 6 hours. The main difference was that the urgent group required more endoscopic therapy, which makes sense. There's been less time for like the body to start the healing process, and you're probably going to have to do more active hemostatic therapy if you scope earlier. So I think really that the clock starts from time of admission. Yeah, so I don't know that necessarily that I think that was, I have to read the trial again, but I'm pretty sure it was time of a presentation in the trial. The exception here is varices, and where they do recommend an EGD within 12 hours, and that comes from our Baveno 7 guidelines. So some considerations about like logistically of like how we're going to scope patients here is one, think about where this is going to happen. These are really general rules. Practice may vary between hospitals and depending on the preferences of the GI, anesthesia, and or ICU teams. But some of our options of where to scope people with the GI bleed include the ICU. We can bring our portable cart up to the ICU and do a scope at the bedside there. We obviously can scope in the endoscopy unit, and we also can scope in the OR. Generally, people who are floor patients are the ones who are going to come down to endoscopy or the OR for their endoscopy. Endoscopy is not open on the weekends, so if you do have a stable patient who you're planning to scope over the weekend, it would have to be in the OR. Anesthesia options include general anesthesia, monitored anesthesia care, or moderate sedation. I think general rules here would be that anyone who's having active hematemesis should have general anesthesia to protect their airway. And certainly anyone in the ICU is likely going to end up needing general anesthesia, primarily because you don't necessarily have an anesthesiologist there to like monitor you during the entire scope. So it's just safer and more stable to get the patient intubated. Monitored anesthesia care, anyone who's not having hematemesis, who's stable enough to come down to endoscopy or the OR, I think is a reasonable option. And then moderate sedation really should be reserved for very stable patients, i.e. those who you are pretty sure have stopped bleeding. Like, for example, you saw someone as a consult on Saturday morning for what sounds like a low-risk GI bleed. You're not going to scope them until Monday. It's been a few days. They're otherwise healthy. And at that point, you're probably very low likelihood of needing to do endoscopic therapy, and they might be appropriate for moderate sedation. Again, think about the resuscitation. Have they been adequately resuscitated before you're going to scope? Again, if someone is like responding well to resuscitation, it's okay to continue that before you do the endoscopy. You don't have to rush in the middle of the night to scope them. But someone who is massively bleeding are going to need to scope sooner, but they at least need to be stable enough to induce anesthesia. And so really working with your ICU and anesthesia colleagues, like when have they gotten enough support that they're not going to like tank their blood pressure when they get induced and intubated? Once they get kind of stabilized, on pressors, the situation is like stable, then you can go in and scope, and you may be needing to do hemostasis to help stabilize the patient further. Think about access. Do they have adequate large bore PIVs? Are they like someone who's exsanguinating the ICU? Does the ICU need to put in a cordis and an A line? Get all of that taken care of before you set up for the endoscopy. Again, and think about time of NPO. So patients can be NPO for need to be NPO for 2 hours after clears, but should be NPO for 6 to 8 hours after anything else like in their stomach. This is really, if someone is needing an urgent EGD due to an unstable upper GI bleed and they ate solid food within 6 to 8 hours, like that is okay. If the scope like really needs to happen sooner, like you can do it. You just need to talk to anesthesia. They'll need general anesthesia and a rapid sequence intubation. And this also might be a setting where you really want to give a prokinetic before you do the scope to kick out whatever is in the stomach. Remember also to get consent before the patient is intubated. It's really a poor form to intubate someone who is otherwise consentable and then having to go like struggle or rushing to find family. So what are we going to find when we do an endoscopy? What are the most common causes of upper GI bleed? Royce, what do you think? What are a few things on your differential with someone with coffee ground emesis or melena?
Peptic ulcer disease, ulcers of other etiologies, H. pylori, like a ton of stuff. H. pylori, there's also just various gastritis from other causes as well.
Great. Yeah. So for sure, peptic ulcer of either due to H. pylori or NSAIDs are going to be far and away the most common cause of upper GI bleed. But also we want to think about other things like obviously varices, gastritis or esophagitis, and then more unusual etiologies like a Mallory-Weiss tear, angiodysplasia or AVMs, doulofoid lesions. And we'll talk about a few of these as we go through. So coming back to kind of our initial patient that you got paged about, you go scope them in the ICU and find this lesion in the duodenal bulb. And how would you categorize this lesion? And Karina, I haven't picked on you yet, so maybe I could ask you, what are you seeing here? Can you describe it?
Yeah, it looks like an ulcer, an ulceration, sort of and then has like a focus of either clot or some sort of like vascular formation in the center.
Yeah, perfect. This is a non-bleeding ulcer with this red thing being a visible vessel. This kind of gets at how we classify peptic ulcers. We use something called the Forest classification, which basically is important because it helps us stratify like how high risk these lesions are. So obviously something that is like actively spurting arterial blood is considered, this is a 1A. 1 is generally your actively bleeding lesion. So 1 is like arterial spurting, 1B is oozing. And then 2 is your kind of higher risk lesions that are not actively bleeding. So 2A, like in the previous picture, this is a non-bleeding visible vessel. 2B is a lesion with an adherent clot. And the difference here is the clot is going to be much like darker, is kind of sitting on top of the lesion. And you may, when you remove it, you may find a vessel underneath, or you may find nothing. And then 2C is a black, like pigmented spot. This is maybe kind of, there was like a little bit of a vessel there, but it's kind of maybe started to heal over. And then 3 is a clean base lesion. There's no high risk bleeding source in the base of the ulcer. And so this kind of stratifies your rebleeding risk. Obviously, someone who is like actively having a spurting hemorrhage, you definitely want to do endoscopic therapy to stop bleeding. And they also have a very high risk of rebleeding even if they stop on their own. Again, something that's actively bleeding, even if it's just oozing, you're definitely going to want endoscopic therapy. And then these ones with the non-bleeding visible vessel, these are really the non-bleeding lesions that are very high risk. Up to 50% of them will rebleed in the first day or two. So these should get endoscopic therapy. Adherent clots, because this clot is kind of hiding the underlying lesion, have a much more variable rebleeding risk. And so it's kind of controversial whether to do endoscopic therapy on those. It's kind of a yes/no situation. If you remove the clot and you see something high risk underneath, then definitely you should treat that. But if you, some people say just leave the clot alone because the clot is part of the body's kind of natural healing process. It's like doing what it needs to do. My practice is to try to like irrigate the lesion with water, and if the clot washes off easily and I see something high risk underneath, then I'll treat it. If it's not very easy to remove the clot, then probably it's like stuck on there and it's like doing a good thing. I will probably just leave it alone. And then these lesions with a flat pigmented spot or a clean ulcer base are already kind of well on their way to healing and have low risk of rebleeding and don't need any kind of endoscopic therapy. So briefly going through some of the other causes of upper GI bleeding that you're going to see commonly. Severe esophagitis, commonly because of gastroesophageal reflux disease or GERD. It definitely actually is a not uncommon cause of coffee ground emesis. We see a lot of severe esophagitis, especially for vomiting. Like LA grade C or D esophagitis can be real causes of upper GI bleed, although rarely like large kind of like hemodynamically unstable upper GI bleed. Mallory-Weiss tears, these are mucosal tears at the GE junction. The typical history you would get here is someone who's vomiting or retching, and it's like non-bloody initially, and then the retching kind of tears the mucosa here, and that leads to then subsequent episodes of bloody vomiting. These often will self-resolve, but in some cases they can be kind of having ongoing bleeding and need endoscopic therapy. Like here, they did some cautery to treat that lesion. Doulofoy lesions are aberrant large caliber submucosal vessels that erode the overlying epithelium without there being a primary ulcer. So these can be difficult to find because they're kind of flush with the underlying mucosa. There's no big ulcer that you're looking for. And so if they're not actively bleeding, these can be really tough to see. But if you do see them, you probably should treat these because I would consider these like a non-bleeding visible vessel, essentially. GAVE or gastric intravascular ectasia are ectatic mucosal blood vessels, which more commonly lead to low-grade bleeding and iron deficiency anemia, much more so than acute bleeding. And we kind of give it the colloquial term of watermelon stomach because of these like streaky red things you'll see. We'll come back to how you'll treat those in a little bit. Angiodysplasia or AVMs are vascular malformations that may appear anywhere in the GI tract. These look like these kind of like red spider-like lesions. We'll commonly look for these as sources of small bowel bleeding. And again, these more commonly present as iron deficiency anemia than overt large volume GI bleeding. Again, so those are some of the common causes that we'll see for upper GI bleed. And these are some of the tools that you have to treat. The epinephrine injection, bipolar coagulation, various kinds of clips, hot or hemostatic forceps, argon plasma coagulation, as well as some newer topical therapies. And I'll go through some of these over the next few slides. So epinephrine injection is basically injecting epinephrine directly into the lesion, which is going to cause vasoconstriction in the local area. And then also the volume of the injection causes some kind of physical tamponade by putting pressure on the vessels in the area. This is not good for monotherapy because, again, that epinephrine is going to sit there for a while, but then eventually it's going to diffuse and wear off. And once it wears off, you haven't actually done anything permanent to treat that lesion. So it is really helpful to help improve visualization. If something is like bleeding so much that you have difficulty seeing, you can inject epinephrine into the area, which is going to slow the bleeding, make it much easier to see what the underlying bleeding source is, and then you can treat that with something else. Just keep in mind, you're probably going to see the blood pressure and the heart rate go up when you give it. Some of that epinephrine is going to diffuse into the systemic circulation and cause tachycardia. Bipolar coagulation or gold probe it really has probably actually the best evidence for treating ulcers of our treatment modalities. There's strong evidence that it reduces both bleeding and mortality, and it's applied by a combination of actual heat coagulation as well as the physical effects. So you take this probe and you press it directly onto the lesion, and so you're really giving some kind of pressure while you're applying the heat. And you want to use the blue pedal, which is the coagulation pedal on your electrosurgical generator. Apply firm pressure and hold it down for about 8 to 10 seconds to really get a good burn on that lesion. I really like this treatment modality for treating non-bleeding visible vessels because you can really kind of seal off that vessel with the coagulation. The gold probes come in two sizes, a 7 French and a 10 French size, and you want to use the largest one that your scope can handle. So if you have a regular upper scope, then you need to use the smaller probe. But if you brought a therapeutic or T1 upper scope, then you can use the larger 10 French gold probe. Some of the models also allow you to connect the water jet directly to the probe, so the water from the scope can come out the tip of the probe instead of from your scope, which can help dislodge the probe from the lesion. Sometimes it gets kind of stuck onto whatever it's burning after the burn happens, and so spraying a little bit of water there can help dislodge the probe. Through the scope clip, these are our standard small hemostatic clips. We use these a lot, but they do actually have less robust evidence than coagulation specifically for treating ulcer bleeding. There is no difference overall compared to thermal contact, aka gold probe, in a few trials, but there was pretty wide confidence intervals, and so they actually have a less higher level of evidence to recommend them than coagulation. These ideally should be used by placing them both over the bleeding site as well as nearby, and the goal is to try to have the probe squeeze whatever the underlying vessel is and seal it off. These are something that we'll really commonly use to close defects and prevent bleeding after things like polypectomy, but they sometimes can be hard to use for treating ulcers. For example, if it's a big ulcer where you can't get the teeth of the clip on either side of the ulcer, that can be challenging to use. And also some ulcers that have been a little bit more chronic can get a little bit kind of fibrotic, and it can be difficult to actually close the clip on the lesion if the tissue is kind of tough. So those can kind of limit your ability to use these in the setting of peptic ulcers. Hemostatic forceps are basically similar to our biopsy forceps, but they're connected to heat. So you could use these, again, using the blue pedal on soft coagulation, and squeeze whatever the lesion is and apply heat to it. So this can be a really good treatment modality for non-bleeding visible vessels as well, or even actively bleeding visible vessels, where you just kind of grab the vessel and burn it. This is very similar to kind of the hemostatic forceps that surgeons will use in laparoscopy, for example. And there was a small randomized controlled trial in high-risk lesions showing increased initial hemostasis and rebleeding compared to using clips. Argon plasma coagulation is basically taking superheated argon gas that we spray out and then ignite on top of the lesion. And this is going to ablate and burn the underlying tissue. And this is a really good modality for both angioectasia as well as GAVE. And you kind of spray or paint the lesion. And especially if you have large lesions, you can kind of spray it over the whole area and try to really ablate that tissue. Again, this is a coagulation effect. You do need to use the blue pedal on the electrosurgical generator. And importantly, it is spraying argon gas into the lumen. So you do want to suction periodically to remove that excess gas and smoke. Over the scope clips are our kind of newer, larger clips. These are kind of much more permanent than our through the scope clips, but are great for treating very high-risk lesions or for lesions that have bled despite initial therapy. They are generally recommended in the guidelines for use of recurrent bleeding, so it may not be the first thing you reach for, but there was a small trial of using them for initial therapy in non-variceal upper GI bleeding, which showed decreased rebleeding complications and transfusions compared to other kinds of standard therapy, although that benefit is primarily for lesions with high-risk stigmata. So someone who really has a life-threatening upper GI bleed, who has a very high-risk lesion, where I want to get definitive hemostasis, that might be a situation where I would use these up front, but more commonly they're going to be used when I've tried other things and it hasn't worked first. Then we also have some of our topical therapies. And so there are a couple of hemostatic powders. One is the TC325 or Hemospray, which is made by Cook. The other is the Endoclot, which is a polysaccharide hemostatic system made by Olympus. There is actually one more powder available now called Next Powder, but I don't think we have it at any of the UCSF sites unless that's changed recently. So I didn't put it on the slide here. But basically, both of these powders work by adhering to blood. So they do tend to work best when there is active bleeding. It does kind of tend to then slough off over 24 hours. And the idea is hopefully the underlying lesion is stabilized and the body's kind of natural healing process has started during that time. But there is concern about potential rebleeding risk because the powder is not going to stay on there for a long period of time. These can be very finicky to use. The powder is going to like clump onto anything that's liquid. So you really need to be very vigorous at drying the channel on your scope before you put the catheter down. It can sometimes be helpful to actually attach the catheter to the carbon dioxide, and have that be spraying CO2 through the catheter before you thread it through the scope. That way that can help like blow out any liquid from the catheter as it's going through the wet channel. And then once you've got it out the tip of your scope, then you take off the carbon dioxide, switch it on to the powder, and then go ahead and spray. Our most common uses for this is malignant tumor bleeding. And especially you can imagine like a big like gastric cancer that's like oozing diffusely. There's not a focal target for other kinds of endoscopic therapy, but spraying this powder over the whole thing can be good at decreasing bleeding. And this is also something that you'll commonly use after failure of standard therapy. So if you've tried everything else and it's like still bleeding, this is kind of your last resort. And unfortunately also once you spray this stuff, you really can't see much anymore. So if you're going to use this in like the acute bleeding setting, this is really kind of the last thing you're going to do after, because you can't really try anything else after you've done this. There's also a topical gel called Puristat, which is a self-assembling peptide gel, which forms this like extracellular matrix-like structure on top of the lesion and kind of creates a transparent barrier that's going to like, in theory, like stop the bleeding and allow kind of healing to take place underneath it. There have been some small studies and a meta-analysis of those for primary hemostasis did show kind of good results. It is also commonly used as prophylaxis after things like EMR or ESD because this does not require active bleeding, unlike the powders. You can kind of put it on a base of a resection defect that you think is going to be at risk of oozing or bleeding later and hopefully kind of decrease that. Finally, again, really old school sclerosing injection, injecting ethanol or ethanolamine directly into a lesion to cause like direct tissue injury and thrombosis. We really don't commonly use this for non-variceal upper GI bleeding, so I'm not going to dwell on that further. Okay, so assuming you've tried all of that and they're still bleeding or they bleed again, we have some options for recurrent or refractory bleeding. Assuming you actually got initial hemostasis and they start bleeding again, it is generally recommended to try again with another endoscopy. And again, that might be a situation where if you tried to like gold probe the first time, it worked, but then they rebled. Maybe that's when you're reaching for the over the scope clip. But if that fails, or if they have like third or fourth episodes of bleeding despite endoscopic therapy, or you're in a procedure and they're still bleeding and you've tried everything, you can't get it to stop, then IR is usually our next step. And our interventional radiology colleagues can embolize the bleeding source. And then surgery is kind of a last resort. It is still used very rarely for massive life-threatening bleeding where they just like go in and oversew the bleeding source. But usually we can do other things before we get to that point. So once you've done endoscopic therapy, assuming you found a peptic ulcer, the endoscopic findings are going to dictate what you do. So, and people who have high-risk lesions get endoscopic therapy, and then they get high-dose PPI therapy after that, which I'll come back to what that is on the next slide. Lower-risk lesions get no endoscopic therapy and get standard PPI therapy. And then adherent clots, again, plus or minus endoscopic therapy, but if they have that adherent clot, you treat them as high dose because they might have an underlying high-risk lesion. So again, high-dose PPI for these high-risk lesions is generally considered to be that IV PPI for BID for 72 hours. Again, there have been small studies showing that like very, very high-dose PO may be acceptable, although that's not standard practice. And also, we do want to watch these patients in the hospital for a couple days after the endoscopy because the risk of rebleeding is highest within those first 48 to 72 hours. And so that generally want to not discharge them before that. And then we continue 40 milligrams BID for at least 2 weeks after discharge. There actually is not great data on how long we should be using PPIs for ulcer healing. So it really is mostly based on expert opinion. And generally, we will recommend actually longer courses, like 4 to 8 weeks for these larger lesions, for these higher risk lesions. I didn't put it on the slide because I don't think practice changing at this point, but there was a trial published recently on vonoprazan for high dose for high risk lesions, and this is obviously an oral potassium competitive acid blocker, and it was not inferior to giving IV PPI in the post endoscopic setting. The limitation here is that these patients were all still observed in the hospital for 72 hours after the endoscopy, so it wasn't like allowing earlier discharge, and I don't know that you would feel safe actually necessarily discharging those patients earlier than that because again they are in that high risk window. Also, vonoprazan is very expensive, and so I don't think there's a cost, even though it's oral, I don't think there's a cost savings to using it right now compared to giving IV pantoprazole. And then for the lower risk lesions, again, you can do standard dose therapy. These patients generally can be discharged immediately after the endoscopy and should get once daily PPI for at least 4 weeks, with the exception being people who have H. pylori, which is confirmed as their source of peptic ulcer. Actually, really only need the PPI for the 2 weeks that they're getting the H. pylori treatment. Once you've eradicated the H. pylori, that has removed their risk factor for developing peptic ulcer disease, and you generally don't need prolonged PPI after that. So again, this is kind of a summary slide here on different kinds of peptic ulcer disease. People who have H. pylori, you should treat that, document eradication, and then discontinue PPI. People who have ulcers due to NSAIDs, you want to stop the NSAIDs if possible. If people need NSAIDs, for example, they have some kind of rheumatologic problem that they need to treat with NSAIDs, you could try to have them switch to COX-2 selective NSAIDs, which are a little more gastric friendly, if possible. And then generally these people, if they need long-term NSAIDs and they've had an NSAID-related ulcer, should be on PPI for as long as they're needing NSAIDs. You're all well aware that we've moved away from low-dose aspirin for primary prevention for cardiovascular events. So if people are still on it for primary prevention and develop an upper GI bleed, then just stop the aspirin permanently. If they are on it for secondary prevention, you do want to resume the aspirin as soon as possible after hemostasis. And these patients generally should be continued on PPI long-term to protect their stomach from the aspirin. And then people who have what we call idiopathic ulcers, which are ulcers that are not due to some kind of defined cause, like commonly H. pylori or NSAID use, or for example, like a stress ulcer in the setting of like severe critical illness and in ICU admission. These are people who, where you're not sure what caused the ulcer, you may want to consider PPI therapy in the long term. In terms of follow-up endoscopy, we do generally recommend a repeat upper endoscopy in about 8 weeks for people with severe LA grade C or D esophagitis. And the reason there is to, again, we want to make sure this esophagitis heals because like ongoing severe esophagitis is going to put them at risk for complications such as esophageal strictures. And it's also hard to diagnose Barrett's esophagus when the esophagus is very inflamed. So you want to recheck to make sure they don't have underlying Barrett's once the esophagitis has healed. And then gastric ulcers can be a presentation of gastric cancer. That's not true of duodenal ulcers. Generally, duodenal cancers would start as like a polyp that develops into a mass, not as a duodenal ulcer. But gastric cancer can appear as an ulcer. So especially large gastric ulcers that appear suspicious for malignancy or a patient with gastric cancer risk factors like a family history. And any gastric ulcer that you don't biopsy on the index endoscopy, you'd want to repeat an endoscopy in about 8 weeks to make sure that it's healed, and then to biopsy if it's still there. So just wrapping up in the last few minutes here, this is just kind of a very brief summary slide. I'm not going to, I'll send you guys the slides later and you can review this, but that just summarizes everything that was in the talk. So again, just a few key points. The key clinical features in patients with upper GI bleed are the quality of the bleeding, the overall patient stability. Our most common causes are going to be peptic ulcer disease, erosions, and esophagitis. It's critical to obtain a good history, very targeted on what could be causing the bleeding, as well as how stable or unstable the patient is, and start that resuscitation early. There is a limited role for urgent endoscopy, really patients who are in refractory shock, where you need to do endoscopy to get hemostasis to help treat their shock. Pre-endoscopy PPI does not affect mortality, but does make your job easier and is again going to start that therapy earlier for the people who are ultimately going to really need that high-dose PPI. Prokinetics help during endoscopy, ideally erythromycin, but metoclopramide is an alternative in a pinch. And the endoscopic findings are going to dictate the need for endoscopic therapy and subsequent medical therapy for how, again, what PPI you're going to give and how long. And then repeat endoscopy for anyone with recurrent bleeding. And in those settings, consider using an over-the-scope clip or hemostatic powders. You're going to start seeing these patients very soon when you're on call, but remember that you always have help available. All the attendings are more than happy to hear from you in the middle of the night and talk about these cases. So thank you all for your attention and participation. Sorry for calling on you out of the blue. Thank you all for being good sports about that. I'm happy to take questions in the last 5 minutes here, and then we'll give you a break before Wasim starts.